Welcome to Pulse and Pressors, where critical care gets crystal clear. In this session, we break down post-operative management after aortic and mitral valve surgery, integrating Swan-Ganz hemodynamics, rhythm interpretation, pharmacologic pearls, and escalation thresholds to mechanical support. Each slide describes what you would see and why it matters. In valve surgery patients, the Swan-Ganz catheter becomes your compass. For aortic valve replacement, the left ventricle is thick and stiff. Pulmonary artery diastolic and wedge pressures often run 14 to 18 millimeters of mercury, reflecting diastolic dysfunction rather than volume overload. Keep mean arterial pressure between 70 and 80 to maintain coronary perfusion. Maintain a cardiac index above 2.2 liters per minute per square meter and a mixed venous saturation above 60%. For mitral valve replacement, the wedge pressure mirrors left atrial pressure directly. After repair, it may transiently rise while the ventricle adapts to its new afterload. Keep wedge between 10 and 15. A normal right atrial pressure is 5 to 8. Rising right atrial pressure with falling cardiac index signals right ventricular strain. Interpret systemic vascular resistance to guide therapy. Low SVR with high cardiac index indicates vasoplegia. High SVR with low cardiac index indicates pump failure. Watch the pulmonary artery pulsatility index. A PAPI below 1.5 means the right ventricle is struggling. This commonly occurs after mitral surgery when unloading the left ventricle suddenly exposes right ventricular interdependence. Support the right ventricle with volume, rhythm, and gentle inotropy until balance returns. Arrhythmias are the most common destabilizer after valve surgery. Atrial fibrillation peaks on days 2 to 4 from inflammation, electrolyte imbalance, and catecholamine surge. Replace potassium to at least 4, magnesium to at least 2, and normalize calcium. Treat unstable atrial fibrillation with synchronized cardioversion and intravenous amiodarone. For stable cases, use beta blockers for rate control if function is preserved. Use amiodarone when function is poor. After aortic valve replacement, conduction block is frequent. Keep pacing wires connected and restore AV synchrony. Never tolerate long pauses or complete heart block. Remember, a stiff LV lives or dies by rhythm and timing. Antithrombotic care depends entirely on valve type. Mechanical valves require lifelong warfarin. Target an INR of 2 to 3 for mechanical AVR and 2.5 to 3.5 for mechanical MVR. Add low-dose aspirin if bleeding risk is acceptable. Begin heparin bridging only after chest tube drainage is minimal and the surgeon approves. Bioprosthetic valves usually receive aspirin alone, though some centers give warfarin for 3 months. If atrial fibrillation develops, follow standard anticoagulation criteria. Never use direct oral anticoagulants in mechanical valves, but they are acceptable in bioprosthetic valves once healing is complete. Sedation should preserve hemodynamics. Propofol provides control but can lower blood pressure. Dexmedetomidine offers cooperative sedation but may slow the heart. Ketamine stands apart. In hemodynamically unstable but non-vasoplegic patients, it maintains sympathetic tone and blood pressure while providing dissociative analgesia. It allows early extubation without hypotension. Think of ketamine as sedation with built-in pressor support. Tamponade can hide in plain sight. Do not wait for hypotension to appear. 2 non-hemodynamic red flags are critical: sudden cessation of chest tube output and new mediastinal widening on chest X-ray. Both can precede collapse. Look for rising central venous pressure and falling cardiac index, but act on suspicion. Call the surgeon and obtain an immediate echo. In cardiac surgery, delay costs myocardium. The right ventricle is often the first to fail. It suffers when afterload spikes or perfusion drops. Maintain oxygenation, correct acidosis, and avoid high PEEP. If pulmonary pressures remain elevated, use inhaled nitric oxide or inhaled epiprostenol. Both reduce pulmonary vascular resistance without systemic hypotension. Keep adequate MAP and sinus rhythm to feed the RV. A strong right ventricle equals a stable patient. After MVR, a hyperdynamic ventricle can pull the anterior leaflet toward the septum, causing dynamic left ventricular outflow tract obstruction. It looks like cardiogenic shock with narrow pulse pressure and a hyperdynamic echo. The fix is counterintuitive. Give fluids to fill the ventricle, use phenylephrine to raise afterload and push the septum back, and slow the heart with a beta blocker such as esmolol or metoprolol. Never give inotropes. They worsen the obstruction. Remember this as your rhythm rescue card. Fill, squeeze, slow. Post-mitral replacement, low output, usually shows elevated wedge pressure and moderate PA pressure. High wedge with low cardiac index means left ventricular failure or afterload mismatch. Treat with gentle inotrope and cautious afterload reduction. Post-aortic replacement patients have stiff ventricles. Their LV end diastolic pressure is high even when wedge looks normal. They need rhythm control, slow rate, and perfusion pressure, not fluid. Vasoplegia is vascular paralysis after surgery and presents as low SVR and high cardiac index. Restore tone and correct with norepinephrine and vasopressin. Use the Swan as your map. Right atrial pressure, or CVP, for preload, PA pressure for RV afterload, wedge for LV filling, and cardiac index for forward flow. Combine these numbers with echo and clinical trends to understand the story, not just the snapshot. If despite optimized preload, rhythm, afterload, and inotropy, the patient remains in low-output shock, escalate early. An intra-aortic balloon pump augments coronary perfusion and lowers afterload in a stunned LV, especially helpful after AVR. If both ventricles fail or oxygen delivery remains critically low, initiate veno-arterial ECMO as a bridge to recovery or decision. Mechanical circulatory support is not a defeat. It is precision rescue that buys time and preserves organs. Echocardiography is your stethoscope. Obtain early post-operative echo to confirm prosthetic motion, valve gradient, and absence of paravalvular leak. Assess left ventricular and right ventricular function, and check for effusion. Repeat anytime hypotension, hypoxemia, rising lactate, or rhythm change occurs. Numbers tell part of the story, but imaging shows the truth. When we choose a valve, we choose not only the material, but also the biology of clot formation. Mechanical valves are durable, but never become part of the body. Their metallic surfaces remain thrombogenic for life, demanding warfarin as a constant companion. Biologic valves, by contrast, are made of living tissue. Within weeks, their sewing ring and leaflets become lined with the patient's own endothelial cells, the same smooth surface that lines natural vessels. Once healed, their thrombosis risk falls sharply, allowing aspirin alone for protection. Transcatheter valves behave similarly, offering tissue compatibility with even less raw surface exposure. Understanding these differences guides every anticoagulation decision and every education moment at discharge. Before transfer, teach the patient sternal precautions, pain management, and signs of infection or bleeding. Review anticoagulation goals and follow-up plans for INR if the patient has been prescribed warfarin and echocardiogram. When patients understand their valve, they protect it. Be sure to watch our video on cabbage surgery before or after, watching this one to tie it all together. This is Pulse and Pressors, reflecting on the marvels of the human body.